So I'm going to begin the recording now. I hope everyone can see my screen. So just to introduce ourselves, I'm Helen, and me and my colleague Lizzie are part of the Oxford RCGP RSC. We've also got, I think, Dan Hartland from TakeATest UK and Helen Campbell from Public Health England joining us, for which we're grateful, as we are to all of you, for taking time out of what must be incredibly busy days to join us to talk about our surveillance work. If I could just ask anyone not on mute to just mute themselves so that I can make sure the recording is nice and clear, and I'll try and do that when it's not me talking as well. So we've booked in an hour for this. I'm hoping we won't take up the full hour and you'll get a bit of your day back. But just to kind of give you an overview of what we're going to cover, we'll look very briefly at what the surveillance network is and what it does, and how our virology and serology swabbing sampling process works, and then we'll have time for your questions later on. So I'm going to cover this first section and then I'll hand over. Just by way of a bit of background, the RCGP programme of influenza and respiratory surveillance has actually been in place since 1967. It was previously at the University of Surrey, the RSC, since relocated to the University of Oxford in 2019. And we now have 1,800 practices involved, starting from about 40 originally. So that's a significant improvement. And in the early 1990s, a programme of work began that involved practices in the network in taking respiratory virology surveillance each year. Originally, that was around looking at the onset of the influenza season and identifying flu strains, which could feed into decisions about which vaccines were made available. And obviously, I think, as you know, since 2020, that's been expanded to include COVID-19, as well as adding this element of serology surveillance, which is incredibly useful on understanding the kind of background population immunity to COVID-19. So I hope you can see how the bringing together of the data that we gather from practices, as well as these new interventional studies, is yielding some really useful information in real time responding to the pandemic. I'm going to introduce Helen Campbell now, who hopefully can talk a little bit about how our surveillance programme works and how it informs practice and policy.
Thank you, Helen. Yes, I mean, just as a very quick highlight of the importance of this work. So the influenza surveillance data is used by Public Health England and obviously the Chief Medical Officer and policymakers to know when the virus is circulating each year, so we can see different flu seasons. They start at different times, they end at different times, and we have very timely data from the RCGP surveillance. And this has been really important in detecting some outbreaks and pandemics such as swine flu and obviously COVID-19 in 2020. And what I would say is, whilst obviously the focus is very much on COVID-19 at the moment, the samples, when you're asking patients to take samples at home, or if you're taking samples in the surgery from patients, the fact that these samples are being tested not only for COVID-19 but for other respiratory viruses is really, really important, because this is one of the only sources of information on this across the country. So we can contribute to clinical and virological data and data on vaccine exposure, and the RCGP data has always been used to generate vaccine effectiveness calculations for flu vaccine each flu season, and will also be used for COVID-19. And one of the other really useful aspects of the RCGP data is the fact that it can add granularity. So, for example, we might be able to look at risk groups within the RCGP data that isn't necessarily available in some of the national data sets. And as you may be aware, the data are included in the
it's all right, it happens a lot.
The weekly national influenza and COVID-19 report. And I don't know, Helen, if you can just click to the next. So this is one of the graphs that's included in that weekly report, and this is in the most recent report that was week 53. So these data are regularly and routinely used and are really, really important to both the flu and now the COVID-19 programs.
Thank you, Helen. That's really helpful. Just a reminder, if you're not on mute, it would be really helpful if you could switch that on just during this section, and then we'll have a section on questions and answers a bit later on.
Actually, and just sorry, one last thing, Helen, that I forgot to mention. That one of the aspects of this surveillance as well is that is really important is the fact that you have denominator data as well as the numerator data for whatever it is that we're looking at, and that is something that we don't always have available through other data sources.
Great, thank you. And I think one thing that we've sort of heard from some practices anecdotally is that patients actually quite like understanding, particularly when we're taking samples for research that maybe are coming back more slowly or where they actually won't get results. They like to know the impact that that data is having. So knowing things like this, hopefully you can communicate that to patients if it's something you think would be of interest to them, that the kind of samples that we're taking are informing these bigger decisions and providing information that we don't otherwise have. So just to continue with the kind of top level view of this, once you are up and running with swabbing or with sampling, there are other opportunities that come up within the network. We have several projects that our swabbing and sampling practices take part in, so you might be aware of the ongoing Principal trial. Lots of our virology and serology project practices take part in that. We actually have a project that some of you may already be aware of around RSV in children that we're currently recruiting from our actively sampling practices. And we have upcoming projects around measles, pregnancy and chickenpox, and a study hopefully around vaccine effectiveness serology, which you may have seen communications about. But once you are an up and running surveillance practice, then these kinds of projects are, I imagine, going to be more and more likely as time goes on. So I'll just pause there to see if there's any kind of burning questions before I move on to this very specific how-tos of the virology work, particularly if Helen or Dan want to jump in, or Lizzie from Oxford. Nope, great. I will jump straight into sort of virology then. I hope all of you are sort of interested in hearing about these, even if you're maybe only focusing on serology. That's coming later. So our virology surveillance program, there's a quick overview of how this works here, just in this flow diagram. The anticipation is that when a patient contacts the practice with symptoms of influenza-like illness, lower respiratory tract illness, or COVID-19, that they would then be offered the option to take a test, either at home or in the practice. The test is then returned by post by the patient directly or by the practice. The sample is then tested, as Helen pointed out, for COVID-19, but also for flu and for RSV, and that there is a sequencing process there that I believe helps us understand not only whether or not a patient has COVID-19 or flu, but which strain. The results are then returned to the patient either via text if they take a home testing kit, or via post or the eLab service directly to the practice, and that result is included in the surveillance data, but alongside, as Helen said, the kind of bigger picture of data that we're getting from practices anyway. A few things to note just as headlines, that as we've kind of already touched on, the turnaround times for research testing may be longer than pillar 2 tests, and patients may feel that they can't wait. It is perfectly okay for a patient to take a pillar 2 test and to receive a further test for surveillance, as that's not a waste, because we do this additional testing. We are testing for flu and RSV, and we are able to do this more in-depth testing. And as I said, patients may appreciate knowing that. We've also had some questions about if patients are receiving a second test for research, they might be concerned that the isolation period, if the test turns out to be positive, will be extended if the second test is a positive. We can reassure people that that's not the case, that the isolation period should be dated from the date of the first positive test, and there is some legislation to support that here. So I've included that link. I'll circulate these slides later, so if you want to click through to read that, that will be available to you. And you can offer a mixture of at-home testing and in-person testing to fit with your practice population. So to go through in a little bit more detail each of those stages, eligibility for virology swabbing is that, as I said, they have symptoms of influenza-like illness, lower respiratory tract infection, or COVID-19, and in patients under 5, acute bronchitis or bronchiolitis. We ask that it's patients presenting up to and including 10 days of symptom onset, and that they are fully able to understand the instructions, or in the case of children, that their parent can understand the instructions on their behalf. And patients of all age groups are eligible, but please do try and include a spread of age groups if you possibly can. I'll go through the 2 types of testing that we can offer, starting with the TakeATest system. I think Dan Hartland from TakeATest is going to talk this through, as he's the expert on this.
That's very nice of you to say, Helen. Yeah, my name's Dan Hartland. I'm the director of Saving Lives, which is the charity that devised TakeATest UK. Best way to think of it is as a digital integration tool. So what it essentially does is it manages every stage of a home self-sampling delivery system, from initial request right through to resulting the patient at the end. And we've been working with PHE and RCGP on this surveillance project since the spring. As you can imagine, home self-sampling, I'm sure I don't need to evangelize about it, but it was particularly useful in the COVID-19 context. But from a patient perspective, the whole idea of TakeATest UK, which Saving Lives developed specifically for research applications, is very, very simple. So it may be very clever behind the scenes, but from a patient perspective, it is designed to be very easy to use. A patient will log on, provide the voucher code that you give them, and we'll talk about that in a minute, and then simply answer some questions and click submit at the end. As far as they're concerned, that's the system, that's the process, and it should be very straightforward. Essentially, the key for a patient using this system is the voucher code, and you'll all be aware that each practice is receiving around about 20 voucher codes every Monday. From the perspective of the practice, each of those voucher codes should be unique. So only one patient can use each voucher code. And that's why we suggest that you make a note of which patient has used which code. We're not prescriptive about how that's done. It's just all we recommend is that you implement it in whatever way best integrates with your current workflows. But the key is just to be aware of which codes have been used by whom. Our system at our end records the voucher code that is used against each request that is made. But from your perspective, it may be useful to know that you're not giving a code out to patients which has already been used. I'm not aware of any case of that happening, though. So obviously you are all behaving. So the process is very simple. Essentially, the only requirement that is really non-negotiable is that the patient has a mobile phone number. That's so that we can send the result to them via text message. We send 2 text messages, one for COVID-19 and one for flu. All of the other viruses that are tested for, such as RSV that Helen mentioned, they're not texted out, but they will be available in the reports from the laboratory. The other thing to think about is making sure that the patient has their NHS number. Strictly speaking, that is an optional field in the system. If a patient doesn't have their number at the point of request and does not fill in that field, the request will continue. But it's good to have that number if we possibly can. Finally, it's worth noting that some patients don't have mobile phones. They can still request. They simply provide an email address instead of a mobile phone number for the validation stage of the process, which is the final screen of the request, whereby we make sure that the details they've given us are correct by sending a 5-digit code to either their mobile phone or their email address. But we can't email results. So where a patient doesn't have a mobile phone number, it will be down to the practice to result that patient. And that is why, as Helen's pointed out on this slide, the code in the CMR is there. And you need to be aware that some patients will need to be resulted directly, but hopefully few. Helen, could you just switch over to the next slide? One thing that we'd like to really make clear is that there is a lot of support. We've built a lot of support for the patient and therefore for the practice into the system. So it isn't a case of every patient that makes a request will, of course, be coming back to the practice to ask for further support. There is a Saving Lives helpline. The number is at the bottom of this PowerPoint slide, which we encourage all patients to contact with any questions they have about the kit or the requesting process, or indeed when they're waiting for their results. So it's only the case really that in that case where I mentioned patients not having mobile phones, that a practice should really have to do anything here. We are here to support the patients through the entire process. Equally, we send text messages out in a variety of circumstances to the patients using those numbers they provided, most specifically advising them to expect that kit within 2 working days. And you'll all be aware, I suspect, of Royal Mail postal issues, if only from the press. The reason that we advise the patients to wait 2 working days and then get in touch with us is so that if Royal Mail has failed to get that kit through to the patient, we can get them another one within the 7 to 10 days of symptom onset. The other end of things, the return to the laboratory, there may be a postal issue there too, but again, we keep in touch with the patients and the patients should keep in touch with us. There shouldn't be any shyness here about patients contacting us, and as I say, we're happy to run interference on the request process for all patients.
Great, thank you, Dan. There was actually a message in the chat that asked almost the opposite question, which was, if a patient has no web access but does have a mobile phone, could they order a test that way?
Absolutely. So that's happened several times already in the course of this project. The best means of doing that is simply to either put the request through on behalf of the patient yourself or ask the patient to contact that Saving Lives helpline. And I have requested several kits on behalf of patients who are in exactly that position. If they have a mobile number and internet access, or indeed if they don't have a mobile number and they don't have internet access, we can still ensure that they get a kit.
That's great, thank you. I think the other component of this, so the second form of taking tests, is the in-practice kits, which you may also be aware of. So these are the same swabs, but they are held in practice for patients who cannot, for whatever reason, potentially to do with technology, or just do not wish to take a test at home. The in-practice kits can be ordered using our materials request form, which is on our website. I've included the link here. It's also in our out of office. If you email the practice liaison team, and it's on the new ORCID website. Those swabs can be held at the practice, and you can then conduct swabs face-to-face if patients are presenting and send the test off using the instructions in the kit. The difference, the biggest difference here, I think, is that the results of in-practice tests only come to the GP. They don't get sent to the patient directly, and you will need to communicate that result to them. I've mentioned on a couple of these slides eLab, and I should possibly touch on that briefly now. That is an electronic resulting system that PHE use. Helen, I wonder if you could maybe give us a bit more detail on that.
Yeah, it is an electronic resulting system that is specific to Colindale, which is where all of the TakeATest and in surgery testing kits will be sent, and it means that you will get those results by email rather than, or you'll be notified that you have a result by email rather than waiting for a posted version, which is the alternative. And if you sign up to eLabs, which I believe most of the virology practices have done, you will receive all of your results that come through Colindale in that way.
Thank you, Helen. That's really helpful. That leads us nicely on to receiving, coding, and communicating results. We've touched on this, I guess, as we've gone along, but it's worth reiterating. TakeATest results are received both at the practice and by the patient directly. If you don't use eLab and you want to, I've included the email address here that you need to contact, including your practice name, your practice code, and your postcode. patients do receive their results via text message. As Dan pointed out, that's only for COVID and for flu. So if they want more details of RSV, for example, patients might contact you to find that out. I've also included a note here that if patients do order a home testing kit, but there is an error in their phone number, so that might be a typo or they simply don't include one, they won't be able to receive those results by text. So you may encounter some patients contacting you and saying, I sent this test kit off and I haven't had a response. And what it turns out is that there's been an error in the text message. This is one of the reasons why keeping a log of voucher codes against who's been issued them is particularly helpful, because we do find at times that we need to track down a patient to provide a result that way.
Helen,
yes.
sorry, Helen.
Go ahead.
I just want to point out that from the TakeATest UK side of things, we keep an eye on all the records too. So we get an alert in our system when a record does not have a mobile number. That won't cover typos, of course, but it does cover the vast majority of cases where essentially there simply is no number. And we notify RCGP of that. So it isn't purely the case that we're waiting for patients to contact practices where they don't receive a result. We're actively trying to spot where they might not receive that result.
Thank you, Dan. Yes, so you might also get an email from us saying, we know that there's an error in this one and they won't be able to receive a result, so could you provide it directly? But yeah, just to reiterate that that's why keeping a log of the voucher code against the patient will be helpful if that is to be something that you'll need to do. And I've mentioned that the in-practice kits result via post or eLab, and you will need to respond to the patient with that result. So I'm going to pause there because that's the end of the virology section. If there's anyone who's desperate to jump off, we're going to be talking about serology next, but there will be a Q&A session at the end. I'm going to hand over to Lizzie to talk about serology now. Lizzie, do you want me to do your slides for you?
Just unmute myself, be helpful. Yeah, that would be great. Again, just to say hello and welcome to everyone. Now, our serology surveillance program in some ways mirrors a lot of the virology surveillance that we do, but with a few differences. Now, one of the main differences at the moment is that with serology, the collection of blood samples is largely opportunistic. So the process is generally one where a patient is scheduled for a routine blood test. At that point, the GP would inform the patient about either about our serology surveillance, and to ask if the patient is willing to take an additional blood sample during their pre-scheduled blood test. That sample, much like the virology sample, is then sent to PHE for testing, and those results are then included in surveillance. One of the key differences with serology is that patients will not receive results of their serology test. And we have patient information sheets that kind of explain this process to patients, also sort of detailing why they won't be receiving those results. And it's essentially, especially in the case with COVID, that we're still in the early stages of understanding COVID, and we don't really have enough information to sort of confidently give that back to patients around what their blood tests might indicate. Next slide. Great. In terms of eligibility, again, the main criteria is that they're being scheduled for a routine blood test. For our general surveillance program, there isn't any further specific criteria around age group, risk factors, or pre-COVID status. But with some of our research projects, like the vaccine effectiveness study that was mentioned earlier in the slide, earlier in the presentation, if you are one of our practices that is a part of the vaccine effectiveness study, there may be further eligibility criteria for serology. And in this case, for vaccine effectiveness, for example, we are looking in particular at older people and are looking to sample more from the main population. But yes, for our general serology surveillance, it's quite broad.
There's a relevant question here in the chat, Lizzie. I don't know if you want to answer it now. That just says, can serology be repeated if patients have already taken part? So I presume if they had regular scheduled blood tests, can they take part each time? And is there a time frame for gap between those?
Yep, that's an excellent question. And for our vaccine effectiveness program study, there is a repeat sampling. But I will point, rather than answering those exact timeframes now, I'll point to the material that we're putting together on this at a later stage.
Great, thank you. Shall I do the next slide?
Great. So for in terms of when kits are being sent off, and this is for our serology surveillance, the materials can be requested for practice kits using our material request form. This is the same process as for ordering those in-practice serology kits that were mentioned previously. And now the serology kits will either come in packs of 25, 50, depending on how many blood samples you think you might be able to collect. And we have a range of different containers available. So if you just make those requests specific in the material requests form, then we can make sure that those kits get sent out to you. And if you have any questions or queries, again, you can always email the practice inquiries email, and we can support you in getting those kits ordered. When you receive the kits, there are going to be some forms that you need to fill out. And I think we're going to be talking in a moment about the importance of filling out those forms as accurately as possible, and also making sure that the relevant information is coded back into the patient medical record.
Just looking at the chat, there's one question about dashboards, which I'll pick up, I think, at the end, if that's all right. And one just asking if the serology study is currently on hold. I don't believe it is. Our standard serology work is continuing, but we're adding this additional element of vaccine effectiveness serology on top of that, for which we're asking for separate expressions of interest. So the standard serology is continuing, and I think we'll notify practices if at any point we decide to stop that. Is that correct, Lizzie?
Yeah. Our serology surveillance is ongoing. Vaccine effectiveness in this case is sort of an added element to the ongoing serology surveillance.
Great, thank you. So that's the headlines around serology. I'm going to touch on, across both studies, the reimbursement process. Practices are paid for samples as long as they are valid and complete. So for virology, what that means is they need to meet the criteria for swabbing. So the swab needs to have been taken within that 10-day onset window. And those swabs are paid at £7.50 each. Serology, there is, as you can see, a range of prices depending on the age of the patient. And those samples need to be complete. And by that we mean completely correctly sealed and labelled. And that for both, there is, I'll just move on to the next slide, there is an element of coding that's required to make sure that we can match those samples. So in order to make sure that we stand the best chance of matching the samples, it's really important that these tests, so both serology and virology, are coded into the medical record system, and there's some guidance on our website about how to do this. I've put a screenshot here. It's actually in a slightly unusual place, so I'll add a link as well so you can find it directly, as it's not actually on the virology and serology page. It's more general guidance about coding for COVID. It's also really important that the patient details on samples and forms are complete and legible, because that's the way that we are able to actually match the samples at the lab level. And it's also really important that samples aren't taken from patients who have opted out of sharing their data, although they may choose to opt back in to take part in research. So that's the really important sort of pieces that can be done from your end to make sure that we can match those samples later. I just wanted to, we were hoping to have one of our friendly practices that come on and help us out with these sorts of sessions with us today, but with vaccine preparations, they weren't able to make it. They did offer us a few insights though, which I wanted to just share because I think they're useful. They highlighted how virology swabbing and the research tests were particularly valuable at the beginning of the pandemic, but continue to be, because when patients are approaching general practice with concern about COVID symptoms, they can actually treat them directly rather than having to signpost them to another service. So that was something that they pointed out was of particular value. They highlighted some of the same challenges as Dan mentioned around turnaround time and missing kits, and also just that uptake was lower now that walk-in testing was more readily available. What I haven't added to this slide, but which was of interest, was the way in which they'd approached recording voucher codes. So they had a shared spreadsheet across their 5 sites, which allowed them to make sure that as a voucher code was being used, it was being logged. So there wasn't any need to worry about repeating giving out voucher codes. So that was just a few short insights from one of our friendly practices. That's all the main content from me. I'll open this up for Q&As now. I see there are a few in the chat, so I'll just run through and quickly respond to some of those. For patients who are not part of the vaccine effectiveness study, I believe the answer is that they can give further samples. I've just seen a post from... Gosh, sorry, I'm struggling to see the whole chat here because of my share screen. Sorry, I'm struggling to read through these questions as it keeps pinging down again.
Is it worth stopping sharing the screen?
Yes, I think that's probably a good idea. I'm going to stop screen sharing and stop recording at this point so we can get some questions. If you're happy to unmute and ask questions, if you've got an urgent one, I can certainly respond to those now. And then perhaps if there are any that we don't have an immediate answer for, we can respond to those in an itemised FAQ when we send out this recording. Sorry, let me just figure out how to stop recording.